Thank you for joining us for the 47th Annual AAKP National Patient Meeting. I'm Lana Schmidt, and I am an AAKP Board of Director and Ambassador for the state of Illinois. I'm a kidney patient, and I was on dialysis for over 13 years, and I was on all the different treatment methods, and currently have received a kidney transplant 6.5 years ago. I am retired, and I help mentor fellow kidney patients throughout the U.S. make the transition into kidney disease and dialysis and through the transplant journey. As a national kidney patient advocate, I've served as a board member and in many different capacities in kidney organizations throughout the United States. I've used my patient voice in publishing newspaper and magazine articles, participating in TV and radio programs, and speaking at conferences, seminars, and meetings. And I also started a kidney patient support group in my community. I was diagnosed with a rare disease, good pastures, and I've been involved in PCORI and other research programs. Being part of AAKP has allowed me to use my patient voice, especially in the government, meeting with government officials and talking with them about kidney legislation and how it can help improve kidney disease health. Also, I have been involved in many research programs, including the PCORI research funding. As an AAKP ambassador, you can do the same. It is critical now that as patient consumers, we raise our voices and create the demand for new diagnostics, devices, and biologics that support earlier identification of kidney disease, along with accurate diagnosis for rare or genetic conditions that may lead to kidney disease. This is why I am so pleased to introduce this session on Lab Values Explained, the importance of knowing your numbers and what those numbers may mean for your health. As a kidney community, the nephrologists use so many different acronyms and nomenclatures that cause barriers for kidney patients to be able to understand what is going on with their health and how to set goals and for their future care. We are very honored to have with us today Dr. Prabir Roy-Chaudhury to help us explain and simplify the understanding of lab values. So we as patients who are the leaders of our healthcare team can better understand our results and what those results mean so that we can best manage our condition and make a plan for our future health that aligns with our goals and inspirations. Dr. Roy, I turn things over to you.
Thank you so much, Lana. It truly is a pleasure to present at the AAKP annual meeting. And right at the outset, I would like to thank the organizers, particularly my good friends and colleagues, Richard Knight and Paul Conway, for this invitation. So what I'm going to do over the next 20 minutes or so is really right at the outset, make the case as to why knowing your numbers is important. I'm then going to go into the three main areas of kidney disease where it's important to know your numbers: chronic kidney disease, kidney transplantation, and dialysis. And when I do this, I'm going to have a particular focus on those numbers which could either change management or which could change your quality of life. And then finally, I'm going to end with a message for the future. I want to start off, though, by really emphasizing a message for the present. And that is, why is knowing your numbers, or why is knowing your numbers so important? And the reason has actually nothing to do with science or biology. But the reason why this is so important is that if you know your numbers, your kidney numbers, you become a partner in your healthcare. You have a vested interest in your healthcare. And in my mind, it's really a recognition that the most important member of your healthcare team is actually you as the patient or as the person with kidney disease. So let's go on and talk about some numbers in chronic kidney disease. So, as many of you would know, it's not really chronic kidney disease, but chronic kidney diseases, because chronic kidney disease could be as a result of diabetic kidney disease, hypertensive kidney disease, glomerulonephritis, polycystic kidney disease, or a host of other conditions. Once you're on treatment for a particular type of kidney disease, however, or when a specific treatment is over, the big question for everybody, whether you're a patient, a caregiver, or a physician, is, what is my kidney disease progression risk? Or, in other words, am I going to go on to dialysis? Am I going to require a transplant? Or can my kidney disease be controlled with medications and good control of high blood pressure and diabetes? And the reason that this is so important, not just at an individual level, but also in terms of society, is that while 1 in 7 people have chronic kidney disease, and while 1 in 4 people over the age of 65 years actually have CKD, only 3% of patients with chronic kidney disease will actually develop kidney failure. So again, the big question is, how do we identify these high-risk patients early so that we can treat them aggressively? And if treatment, unfortunately, as sometimes happens, doesn't work, we can prepare them for dialysis or a transplant. And the way to do it actually is, in my mind, a tale of two numbers. So this is the KDIGO heat map, if you will. And on the left hand side, you can see that you have a range of GFR. So what's GFR? GFR is your glomerular filtration rate. It is calculated, if you will. That's why it's called an estimated GFR from your creatinine. A normal GFR, which we often refer to as your kidney number, is over 90, let's say 100. And then you have these different grades. G2 is 60 to 89, G3 is 45 to 59, and then you have G3B, G4, and G5, which is really under 15, which is kidney failure, when you really are very close to requiring dialysis or a transplant. But it's not just the degree of kidney dysfunction or a low GFR that is important. The other really big number that's important is the amount of albumin that you're excreting. And we divide it now into 3 categories: A1, A2, and A3. So A1 is almost no leakage of albumin in your urine. A2 is 30 to 300, and A3 is greater than 300. So why is this important? Well, it's important because if you look at a patient, for example, in the G3A stage, who has a moderately decreased GFR at 45 to 59, if this person is only excreting a small amount of albumin, he or she comes into the yellow range. So green is normal, yellow is mild risk, orange is moderate risk, and red is a very high risk of progression. The same person, or let's say another person who also has a GFR or a kidney number of 45 to 59, but in fact is excreting 30 to 300 milligrams of albumin every day or per gram, then this person, even though the eGFR is the same, comes into the moderately increased risk group. And then if you have somebody who's excreting more than 300 milligrams of albumin, then even though the eGFR is that same 45 to 59, this person comes into a high risk group. So it's always a combination of your EGFR, which is derived from the creatinine, and we'll come to that in a moment, and the amount of albumin you're excreting. But the problem with this is that it's not so specific. So you have all of these different red zones. Do they all mean the same? And the next slide really is going to describe, or the next two slides, something called the kidney failure risk equation, which has really taken that KDIGO heat map and, in my mind, converted it into a much more patient-friendly format. So let's suppose you are a 50-year-old male. You have an EGFR of 20, so you've got advanced kidney disease, and you're excreting 3 grams of albumin, 3,000 milligrams of albumin per day. So you're definitely in that A3 category. So if you put this patient into the KDIGO heat map, the patient comes in where the X is. So severely decreased GFR, right? GFR is 20. So that's G4, and a very significant amount of albuminuria, over 3,000 in this case. And so the risk is high. So that's all well and good. But again, can we be more specific? And the way to be more specific is to use the kidney failure risk equation. And what this does is it basically takes the data that I described before, 50-year-old male, EGFR of 20, excreting 3,000 milligrams of albumin, and it puts it all together in an algorithm that then spits out the actual risk of that individual patient progressing to kidney failure requiring dialysis. And in this particular person, the numbers are 62% at 2 years, 95% at 5 years. And as a physician, and I would say as a patient, the plan for this person, unfortunately, is we need to get you ready to, in my mind, to get a preemptive kidney transplant before your kidneys fail completely. And if that's not possible, we need to prepare you for dialysis by placing either an arteriovenous fistula or talking about peritoneal dialysis. So this percentage actually gives you a much better idea than just saying that you're in the red zone or the orange zone. So let's take another patient. So let's take a 75-year-old woman in this case who's got an EGFR of 29. So the kidney function's a little bit better, but it's still in that 15 to 30 G4 range. But the difference here is that she is excreting very little albumin. So let's see where she lands up on the KDIGO heat map. So she lands up again in the red zone in the KDIGO heat map because her GFR is severely decreased. And if your GFR is severely decreased, doesn't matter whether you're passing a little bit of albumin or a lot of albumin. Let's put her into the kidney failure risk equation. And what you see in the kidney failure risk equation, that at 2 years, she's got less than a 2% chance of developing end-stage kidney disease. And at 5 years, it's about 6%. So the message for this woman at the age of 75, in my mind, very strongly is you need to follow up with your nephrologist. You need to have good control of your blood pressure and your diabetes if you have diabetes. You need to be on the right drugs to prevent further progression that your nephrologist has put you onto. But you're not going to go on to dialysis. Keep walking, keep playing golf if that's what you're doing, keep cooking, lead your normal life. The prognosis is good. And that is so important, I think, both for the patient, for all of you, and for the physician and for the healthcare system as a whole. So let's move away a little bit from chronic kidney disease and talk about some numbers related to kidney transplantation. And I smile when I speak about this because I am a transplant nephrologist, and I'm going to divide this section into 2 bits. So the numbers that are important when you're on the waiting list for a transplant, and the numbers that are important after you get a transplant. So one of the numbers that you'll hear a lot when you're on the waiting list for a transplant is something called the cPRA, and it stands for the calculated panel reactive antibody. And very simply, it's really an estimate of the percentage of people in the general population that you, as somebody on the kidney transplant waiting list, are going to react against, in terms of you have preformed antibodies against these general people in the population from which your donor is going to come. So if you have no antibodies, 0 is your PRA, and that's good. If you have antibodies against almost every type of donor, you have a calculated PRA of 100, and that is bad. So why is it bad? Well, the answer is on this in the slide on the left, which really shows on the y-axis the percentage of people who don't get a kidney transplant, and then on the x-axis the number of years on the waiting list. And the message here is that if you have a high PRA, then at 10 years on the waiting list, only about 15% of patients have actually got a kidney transplant. On the other hand, if you have a much lower PRA, so you're not so immunologically reactive, if you will, then at 10 years, the vast majority of patients on the waiting list would have got a transplant. So the cPRA is really important. And again, I don't want to be doom and gloom for some of you who have a high cPRA. We now have ways that we can try and desensitize patients, and we also have a very active kidney swap program, the National Kidney Registry, which can help you if you have a high cPRA and if you have a living donor. The other number that you'll often hear is something called the Kidney Donor Profile Index. And this really denotes the quality of a deceased donor kidney. So again, 0 is good and 100 is bad. And in general, we use a number of less than 85 as being okay for transplant, although clearly we can also use a lot of kidneys that have a KDPI of more than 85. So what does that number mean? So if you have a number of, let's say, 70, it means that of all the kidney donors that were harvested, let's say, in a given year, 70% of them were better than you. If you have a KDPI of 30, it means that only 30% of kidneys that were used in the last year were actually better than your kidney. And of course, if you have a KDPI of 5, that means that this is a really good kidney. So what goes into the KDPI? And this is all really done by a computer. So let's take an actual example. So let's say you're 61 years old, you're 5'7", you're overweight, unfortunately. And I'm not talking about you here. I'm talking about the person who unfortunately has passed away but is willing to donate a kidney. So that person is actually a hero, always a hero. So we're talking about a hero who's 61 years, 5'7", Asian ethnicity, has had a history of hypertension, no diabetes, died in a road traffic accident, has a good serum creatinine of 1.2, does not have hepatitis C, and is not a donor after cardiac death, which means that the heart is currently beating, but the brain stem or the brain is dead. So if you put all of these numbers into the calculator, you get a KDPI of 78, which means that 78% of all the kidneys that are harvested are likely to be better than this one. I would come out very clearly and say, this is a good kidney. So I wouldn't put this kidney into somebody who's 25 years old, but I would have no hesitation in putting this as quickly as possible into somebody who's 55, 60 or more. This is a kidney that's going to work. I want to show you the impact of age. So over here, it's exactly the same characteristics, but the only thing I've changed is that I made this donor 30 years old, and the KDPI immediately improves to 27%. So this is a really good kidney that could go into a young person, obviously. So moving on for KDPIs, the other thing that you'll hear about is the flow cross match. So what exactly is this? So this is a test that's performed prior to a transplant when you're on the waiting list. And what happens over here is that you add recipient serum. So if you are a kidney patient, you add your serum to T cells and B cells from the donor, as shown in the middle panel. And what you're looking for is you're looking for preformed antibodies. So these blue sort of schematics that I've shown I unfortunately don't have an arrow. So if you have preformed antibodies in your blood that react against the T cells and B cells and other tissue of your donor, you have a positive cross match and you cannot get this kidney, because if you do, the antibodies in your blood would attack the kidney and really destroy it right in the operating room. On the other hand, if your antibodies do not react against the donor T cells and B cells, it's a negative cross match and you're good to go for a transplant. So, what about the numbers that are important after you get a kidney transplant? And the big message I want to put out is it really is all about the creatinine. That's what we talk about. I want to speak a little bit more about the creatinine. What exactly is the creatinine? So, creatinine is a molecule in your body, it's produced by your muscles. And when your kidneys fail, your creatinine increases. A normal creatinine is 1. If you have a creatinine of 10, you probably need dialysis. Now, I had mentioned the other kidney number earlier, which was the eGFR. It's important to remember that the eGFR, in a way, is more accurate or more sensitive than the creatinine, but it's calculated from the creatinine. And one of the things that I think the kidney community and I think patient advocates in particular should be really proud of, that we recently had the correction for race that was there on the calculation of the GFR that has been removed. Let's talk a little bit about how creatinine translates into eGFR, and that'll bring out the importance of recognizing that even small changes in creatinine are actually quite important. So if you have a creatinine of 1, and this is for a 40-year-old man who weighs about 160 pounds, then your GFR is 98, which is great. But if your creatinine just goes from 1 to 2, you have this huge drop in your glomerular filtration rate, which is an indicator of your kidney function, from 92 to 42, which means that even a small rise in creatinine in a transplant patient from 1 to 1.5 could signify, as you see in the right panel, a very significant drop in your kidney function. A creatinine of 5 is equivalent to an eGFR of 14 and a creatinine of 10 to 6. So again, see the difference. Going from a creatinine of 1 to 2, you lose almost 50% of your kidney function. But going from 14 to 6, you lose about 8% of your kidney function. So with that background, so this slide expands a little bit about important issues with regard to the creatinine when you have a transplant. And the first thing is that when you get a transplant, in the first few days, your creatinine comes down really quite quickly. But at about 2 to 4 weeks, you and I, as the physician, because it's a team, remember, are able to identify a baseline creatinine. And, often I'm sure your physician, for those of you who've had a transplant, will say, we're going to put your baseline at between 1.2 to 1.4. So the reason that's important is that we always look at that baseline, and if you go 20% above that baseline, or in many cases, if you have a creatinine increase of about 0.3, then that means that you need to be looked at more closely. And we'll speak a little bit about what that means in the next slide. But at a clinical level, are you dehydrated? Have you been taking your medicines? Do you have an infection? Or if you rule out all of these things, do you have a rejection episode? So remember, an increase in 0.3 when your creatinine is about 1 to 1.5 and you have a transplant is important. But also remember that you could have a transplant and your creatinine is 4 because unfortunately it's been failing. In that setting, a creatinine rise from 4 to 4.3 may not mean as much, because as I showed you on the previous slide, that really equates to just a small change in kidney function. But 0.8 to 1.1, that's a big change. And again, I've made that point below, that 0.8 to 1.2, for example, could mean a very significant loss of function. But it's not just the creatinine. And all of you who've had a transplant will know that in addition to the creatinine, we always ask about the tacrolimus levels or the TAC level. So tacrolimus is an immunosuppressive agent. We use it in about 90% plus of kidney transplants in this country. We measure the levels very closely. So in the first 3 months, you should have a level about 7 to 10. If you're a second kidney, if you've had previous rejections in the first kidney, I would go for a slightly higher level. But after that, you're talking about a level of 5 to 8. Now, tacrolimus is a double-edged sword. So on the one hand, it's a great drug to prevent rejection. But on the other hand, if your levels are too high, it can cause kidney toxicity, so your creatinine goes up. What you need to do is to reduce the tacrolimus dose. And if your tacrolimus level goes too low, then you can get rejection. And the other message, it's not really about a number, but it's really important. There are many drugs that can increase the concentration of tacrolimus or decrease it. And so if somebody puts you as a kidney transplant patient onto a new medicine, please let your transplant physician know before you start taking that medicine. And then finally, just a little bit about donor-specific antibodies and some infection numbers. Over the last 10 years, we've got the ability to be able to measure new antibodies against your donor kidney that develop post-transplant, and these are against what we call donor HLA antigens. When should you measure DSAs? Well, different centers measure it in different ways. I think you should always measure a DSA when the creatinine goes up because you really want to assess for antibody-mediated rejection. It can be done based on a protocol, of course, at 1 month, 3 months, and 1 year. And if your DSA suddenly goes up, that would push you towards a biopsy. And it's often measured in terms of mean fluorescence intensity. You don't need to worry about that too much. It's called MFI. But if somebody says that you've got a positive DSA and your MFI is 5,000, that's important because that's a significant level of donor-specific antibodies that could then damage your kidneys. A little bit about infection. Most transplant centers will measure something called a BK virus PCR in your blood. A level of more than 10,000 is very significant. And the treatment, if you have this BK viremia, is to reduce your immunosuppression. And we really got quite good at treating BK virus nephropathy by reducing immunosuppression. So finally, moving on to hemodialysis, and I'm just going to talk about a few things. Dry weight, hemoglobin and iron stores, potassium, and then phosphate and parathyroid hormone. So let's talk about dry weight. And so the dry weight, or your estimated dry weight, is that number which tells you what your weight should be at the end of dialysis. And the reason that it's important is that it has to be just right. So if your dry weight is pegged too high, let's say at 80 kilos when it should be 75, that means you're going to be wet at the end of dialysis. You're going to be short of breath, you're going to be tired, you're going to have swollen ankles and a high blood pressure. On the other hand, if we've made your dry weight too low, in other words, you're going to be dry at the end of dialysis, you're going to be dizzy, you're going to be falling over, you're going to have nausea and vomiting, and a low blood pressure. And of course, if we've got, and when I say we again, it's the dialysis team and it's you as the patient, right? That's the team. But if we've got it just right, then you're going to feel good, you're going to have more energy, your BP or blood pressure would be just right, and life in general is going to be better. So getting your dry weight correct is very, very important. One of the points to remember is that dry weight is dynamic. So let's suppose you put on muscle after an illness. Well, then your dry weight also needs to be increased, otherwise you'll be too dry at the end of dialysis. On the other hand, if you're deconditioned and you lose body mass, then your dry weight needs to be decreased, because if you don't decrease your dry weight in this setting, you'll end up too wet at the end of dialysis. If you have a high blood pressure, we can often treat it by decreasing your dry weight. If you have a low blood pressure, we often increase your dry weight a little bit to see how you feel. Now, there are devices like the CritLine that are used in many dialysis units, but again, I'm going to put this out there. You, as the patient, are often the best judge of your dry weight. Please talk with your dialysis nurse or technician or nephrologist and work out what exactly is the dry weight at which you feel best and where your lungs are clear and your energy is good. So let's talk a little bit about hemoglobin and iron. So that's always important in the dialysis unit. The target hemoglobin is between 11 and 12 grams per deciliter. If you want to have a good hemoglobin, you have to have enough iron in your blood so that your bone marrow can produce red cells. And the appropriate iron saturation is about 30%. And the comment that I would make as a summary at the end is that most hemodialysis patients will be on some combination of erythropoietin and iron infusions to increase their hemoglobin and get it to that 11 to 12 level. Potassium. So potassium is important because high and low potassium can both kill you. The ideal level is between 4.6 to 5.3. And as those of you on dialysis know, we dialyze your blood against different concentrations of potassium in the dialysis machine. That could be a 2K bath, a 3K bath, or a 4K bath. I will say that diet is absolutely key, but we are beginning to use new potassium binding drugs like Lokelma and Veltassa. And the importance of these drugs is that if you're on them on a regular basis, we don't have to use a low potassium dialysate bath. And so we avoid big shifts in potassium during dialysis. And of course, if you shift your potassium from a 6 to a 3 during dialysis, that can actually strain the heart. And then finally, phosphate. So phosphate is the bane, I think, of patients on dialysis. I think it's hard to control your phosphate. Almost everything we eat, or at least the good things in life, as in food or good food that you like, has phosphate. The ideal phosphate level is 3.5 to 5.5. Linked to phosphate, you're also going to hear about your parathyroid hormone level. So there's this balance between calcium and phosphate and your PTH level. The normal PTH level is 2 to 9 times the upper level of normal. So that's a pretty big range, as you can see on this slide. And the way to get a good phosphate is to be on a low phosphate diet. Can be very difficult, but really important. You need to use phosphate binders, for example, like sevelamer or Foslo. And for patients who have a high PTH, which could damage the bones, we use drugs like cinacalcet or Hectorol or calcitriol. So what about the future? So I'm coming to the last two slides, and this is really my message for the future to all of you. We need to individualize the care of kidney patients in the future. I think we need to move towards a more precision medicine-based approach. We absolutely need to recognize that each and every patient is different. And we as physicians and the healthcare system need to tailor our treatment so that we take into account not just biology and clinical parameters, but also the demographics and the social determinants of health and the environmental factors and so much more that all of you as patients have. And the reason to do this is, or the reason we have to do this, I'm going to be much stronger, is the reason we have to do this is because this is what's going to allow us to get the right treatment to the right patient at the right time. This is what individualized medicine is all about. This is what precision medicine is about, where we start treating you as an individual person, where we treat the individual, not the population as a whole. So that's my dream anyway. I hope it's your dream also. And I really do believe that I think we've come a lot closer to achieving that dream. The reason I say that is that we have a powerful new initiative that the NIH has launched called the Precision Medicine Project. So if you ask me, based on the previous slide, can this really happen? My answer is yes, it can, and yes, it will. And the reason I say that, in this kidney precision medicine project, we're actually doing biopsies of patients with early kidney disease And when we do a biopsy, we are studying those cells in incredible detail. So we are teasing out all of the different cell types in the kidney, and we are trying to learn how each of those cell types behaves and interacts with each other in that particular patient. And it's going to be different in patient A as compared to patient J or patient Z. But the beauty is that once we have that information, once we create a kidney atlas, once we have the bioinformatics that we can plug this data into, that's when we're going to be able to predict at a very early stage of kidney disease, you're going to have aggressive kidney disease. We need to treat you aggressively. And when we understand what these cells are doing, we're also going to understand mechanisms that can be converted into new therapies for you as an individual patient. So, patient A with diabetic kidney disease and a creatinine of 2 may be treated in a completely different way from patient B with exactly the same parameters, because their kidney says patient A has a different type of chronic disease that's more aggressive, while patient B is going to do really well. So, with that last dream for the future, if you will, I am going to end this presentation. I want to thank you all so much for your attention. And this is just a wonderful, wonderful meeting, both to have and to speak at. Thank you again for your attention.
Thank you, Dr. Roy, for an excellent and important presentation. On behalf of AAKP, I want to thank you for sharing your time and expertise with us.